What if I told you that one of the most effective treatments we have for a really prevalent form of cancer involves taking a live, weakened strain of tuberculosis and just injecting it directly into the patient's body?
I mean, it sounds completely counterintuitive, right? It sounds like something out of a weird 19th century medical experiment.
Exactly. Intentionally introducing a pathogen to fight a tumor. It's wild.
It is, but relying on that biological paradox, using an infection to trigger an immune response,
Yeah.
it's actually a cornerstone of modern oncology for this specific disease.
Right. And that brings us to our focus today. We're doing a deep dive into the official ESMO. That's the European Society for Medical Oncology, their clinical practice guideline for the diagnosis, treatment, and follow-up of bladder cancer.
Yeah, and it's a massive document.
It is. Okay, let's unpack this, because reading through this guideline, it isn't just looking at a boring list of drug dosages. It functions as a masterclass in tumor biology and medical strategy.
Oh, absolutely.
It maps out exactly how the global oncology community adapts to this highly stealthy evolutionary disease.
Yeah, what makes this document so incredible is how it synthesizes decades of global clinical trials, epidemiology, and, well, some of the most advanced genetic sequencing we have in medicine right now.
Mm-hmm.
It provides this really comprehensive flowchart that tracks the disease from the very first subtle warning signs all the way to complex, individualized genomic warfare.
So for you listening, whether you're a medical professional tracking the standard of care, or maybe someone looking at your own family history, or just someone fascinated by the cutting edge of personalized medicine, this deep dive is going to map out that entire battlefield.
Right. We're covering a lot of ground today.
Yeah, we'll look at the silent alarms, the localized treatments, and that massive shift to highly targeted therapies.
And I think the logical starting point here is the epidemiology.
Right, the numbers.
Exactly. Before we even talk about treating the disease, we have to look at the global footprint of urothelial carcinoma and the specific risk factors that drive it.
And the scale is just massive. I mean, urothelial carcinoma is the 10th most common cancer worldwide. The guideline cites an estimated 549,000 new cases and like 200,000 deaths in a single year.
It's a huge burden. And the geographic distribution is actually really interesting. It heavily skews toward Southern and Western Europe.
Oh, really? Like where specifically?
Well, nations like Greece, Spain, Italy, Belgium, the Netherlands, they show the highest incidence rates globally.
Wow. And the driving force behind those numbers becomes, well, it becomes really clear when you look at the primary risk factors.
Right.
Because a full 50% of these cases are directly attributed to tobacco smoking.
Half of all cases. It's staggering.
It is. And then the secondary major risk factor involves occupational exposure to aromatic amines.
Right, which are chemicals historically used in like the dye industry,
Yeah.
rubber manufacturing, certain paints.
Yeah. But I really want to focus on that connection between smoking and bladder cancer for a second, because, conventional wisdom links smoking almost exclusively to lung cancer or throat cancer.
Right, people don't immediately think of the urinary tract.
Exactly. The mechanism of how inhaled smoke translates to a malignancy in the bladder is, well, it's a fascinating look at the body's filtration system.
It really is.
Yeah.
The connection relies entirely on renal physiology.
Yeah.
So when tobacco smoke is inhaled, thousands of these chemical carcinogens cross the alveolar membrane in the lungs, and they just enter the bloodstream.
Okay.
And the primary job of the kidneys is to filter that blood, right, to remove waste and toxins.
Right. That's their whole purpose.
Yeah. So the kidneys extract these water-soluble carcinogens and excrete them into the urine. But because the bladder acts as a storage reservoir, that urine doesn't leave the body right away.
It just sits there.
Exactly. It sits there sometimes for hours at a time.
Yeah.
So the urothelium, which is that really delicate inner lining of the bladder, is continuously bathed in a highly concentrated pool of these toxins.
Oh, wow.
Yeah. Over years and decades of that kind of exposure, that localized chemical stress basically forces the cellular DNA to mutate.
So the bladder is essentially forced to act as a holding tank for the exact poisons the body is desperately trying to clear out.
That's exactly it.
It makes perfect sense why the urothelium eventually begins to rebel. And, that leads to the initial clinical presentation. The guideline notes that about 80% of patients first present with painless hematuria, which is blood in the urine.
Yeah. This raises an important question, focusing on the intersection of tumor biology and patient psychology.
How so?
Well, hematuria, without any associated flank pain or burning, is a highly insidious symptom. I mean, think about it. Pain acts as an evolutionary alarm bell. demands immediate action.
Right. If you're in pain, you go to the doctor.
Exactly. But when a symptom is completely painless, the psychological urgency just vanishes.
Oh, I see. It's like a house's plumbing system. If you see a little rust in the water, but the pipes aren't leaking and they aren't making any weird noises, it's incredibly easy to just ignore it.
That's a great analogy. A patient might notice a slight discoloration in their urine, but if it clears up the following day, the natural human tendency is to dismiss it as a fluke.
Right. You just tell yourself you ate something weird.
Yeah. And meanwhile, the tumor continues to proliferate entirely unhindered.
So the lack of pain provides the cancer with this massive window of opportunity. But once the patient does finally present to a urologist, the diagnostic protocol kicks in.
Hmm.
And the guideline mandates a cystoscopy to visualize the bladder wall, followed by a surgical procedure called a 2RBT.
Right, a transurethral resection of the bladder tumor.
Yeah. And the text is incredibly specific about the technical requirements of this biopsy. It's not enough to just scrape the visible tumor.
No, not at all. The surgeon is absolutely required to capture a sample of the underlying detrusor muscle. Capturing that muscle tissue is the single most critical step in the initial staging process,
Why is the muscle so important?
because the pathology report has to confirm whether the malignant cells are just confined to the superficial urothelium or if they've actually invaded the muscular wall of the organ.
Oh, okay.
That one anatomical distinction dictates two entirely divergent treatment paradigms. It's a huge fork in the road.
Well, the data shows that 75% of patients are initially diagnosed with non-muscle invasive bladder cancer, or NMIBC.
Right.
Now, when I hear the term non-muscle invasive, my intuitive leap is that the cancer is localized, like it's sitting purely on the surface. If it hasn't hit the muscle, isn't it just a simple scrape-and-go procedure?
I get why you'd think that, but no. The biological reality of NMIBC is far more complicated.
Really?
Yeah. While overall survival rates for non-muscle invasive disease are excellent, the recurrence rates are notoriously high. For high-risk patients, up to 50% will experience a recurrence within 5 years.
Wait, 50%? Even after they scraped it out?
Yes. And the concept at play here is called field cancerization.
Field cancerization.
Yeah. Remember how the entire urothelium has been subjected to that same carcinogenic bath for years?
Right, the holding tank of toxins.
Exactly. So even if you remove the dominant visible tumor, the surrounding tissue remains genetically unstable. It's basically primed to develop new malignancies.
Right.
So resection alone leaves the hazardous microenvironment completely intact.
Which necessitates intravesical therapy. This is where, instead of systemic drugs that flood the whole body, the physician administers medication directly into the bladder via a catheter, just letting it pool right where that field cancerization is occurring.
It's a very targeted approach.
And for low-risk cases, the guideline suggests a single installation of a chemotherapy agent like mitomycin C.
Right.
But for intermediate and high-risk NMIBC, we come back to that tuberculosis vaccine we mentioned right at the start.
Yes, BCG, Bacillus calmette-guerin.
Right. The standard protocol requires administering this live bacteria into the bladder repeatedly, sometimes for up to 3 years. Like, how does that actually work?
Well, BCG is actually one of the earliest and most elegant forms of immunotherapy in the history of medicine. The mechanism of action is brilliant in its indirectness.
Okay, indirect how?
Urothelial carcinoma cells are remarkably adept at evading the body's immune surveillance. They just hide. But by introducing a weakened strain of tuberculosis into the bladder, the physician intentionally provokes a massive, localized inflammatory cascade.
Oh, I see.
The immune system detects the bacterial threat, panics, and floods the bladder lining with macrophages, natural killer cells, and T cells.
So it's a biological equivalent of staging a highly visible bank robbery just to get the entire police force to swarm the building, knowing they'll inevitably stumble upon the stealthy criminals hiding in the vault.
That's a perfect way to describe it. The inflammatory environment hyperactivates all those immune cells.
Mm-hmm.
And once they're deployed to the urothelium to fight the BCG bacteria, they finally begin recognizing the tumor-associated antigens on the residual cancer cells that had previously just gone totally unnoticed.
Wow.
So the immune system ends up eradicating the microscopic disease that the surgeon's scalpel couldn't even see.
That localized strategy is fascinating. But the guideline outlines a massive pivot if the initial pathology report shows that the tumor has breached the detrusor muscle.
Right. That changes everything.
Yeah, for muscle-invasive bladder cancer or MIBC, BCG and scrape-and-go procedures are instantly off the table.
Completely. The standard of care for muscle-invasive disease requires a rapid escalation to radical cystectomy.
Which is the full removal of the bladder.
Exactly. The complete surgical removal of the bladder, along with the adjacent regional pelvic lymph nodes. Once the cancer accesses the deep muscle, it gains proximity to the lymphatic and vascular systems.
Right.
So it fundamentally changes the threat level from a local nuisance to a potential systemic crisis.
Here's where it gets really interesting, though, because the protocol isn't to just rush the patient straight to the operating room the moment muscle invasion is detected.
No, it's not.
The guidelines strongly recommends a regimen of neoadjuvant chemotherapy, specifically administering systemic cisplatin-based chemotherapy before the radical cystectomy.
Yes, that pre-surgical strike is crucial.
The clinical data shows this yields a 5% absolute increase in 5-year overall survival and a 9% increase in disease-free survival. I was thinking about the logic here, and it seems really similar to a pest control strategy. Like, if you tear down the drywall of an infested house first, the termites just scatter.
Yeah.
But if you tent and fumigate the house while the walls are still up, you kill the primary colony and the invisible stragglers before you even begin demolition.
The fumigation metaphor aligns perfectly with the concept of micrometastases.
Okay, tell me more about that.
Well, if a tumor has invaded the detrusor muscle, the statistical probability that microscopic clusters of cancer cells have already entered the bloodstream or lymphatic system is incredibly high.
Oh, wow. So they're already out there.
Exactly. A radical cystectomy will successfully remove the primary tumor mass, but it does absolutely nothing to address those invisible circulating rogue cells.
And if you wait until after the surgery to administer the chemotherapy, like adjuvant therapy, you run into the reality of surgical recovery.
Exactly. A cystectomy is a profoundly taxing procedure.
Right. The patient often faces functional decline, weight loss, just a really extended recovery period.
And during that multi-month recovery window, the patient might not be physically strong enough to tolerate the aggressive toxicity of cisplatin.
Ah.
Meanwhile, those micrometastases are out there establishing a blood supply and multiplying in other organs.
That makes total sense.
So by utilizing neoadjuvant chemotherapy, you hit the systemic disease at a moment when the patient's physiological resilience is at its absolute peak. Cisplatin basically works by directly binding to the cancer cell's DNA. It creates these crosslinks that prevent the DNA from unzipping and replicating, which ultimately triggers apoptosis or programmed cell death.
However, the guideline is very clear that not everyone is a candidate for this approach. I mean, cisplatin is a heavy-duty platinum compound.
It's very intense, yes.
And clearing it from the body requires robust kidney function. If the cancer, or maybe other comorbidities, have compromised the patient's renal clearance, administering cisplatin could cause irreversible kidney damage.
Right. Nephrotoxicity. It's a huge concern. And for patients who are medically unfit for a radical cystectomy, or for those who just strictly refuse the removal of their bladder, the guideline does provide an organ-sparing alternative.
Okay, what's that?
It's known as trimodal therapy. This involves an aggressive maximal TURBAP. So they go in and remove as much tumor burden as physically possible, followed immediately by concurrent radiation therapy and radiosensitizing chemotherapy.
Wow, hitting it from all sides.
Exactly. The goal is to cure the muscle-invasive disease while preserving the native organ. But the caveat is that the patient has to commit to a lifetime of rigorous cystoscopic surveillance.
Because the bladder is still there.
Right. The risk of a local recurrence in that preserved bladder remains a persistent threat.
So the treatment pathways diverge massively based on the patient's specific physiological reality. But, the most complex section of the ESMO guideline actually addresses the scenario where the cancer has outsmarted those initial interventions.
Yes. Metastatic disease.
Right. When the disease metastasizes, spreading to the liver, lungs, or bones, the surgical options basically fade into the background.
Unfortunately, yes.
The treatment of advanced or metastatic urothelial carcinoma is heavily reliant on a rapidly evolving pharmacological arsenal.
And the traditional first-line foundation for metastatic disease remains platinum-based combination chemotherapy. So if a patient has adequate kidney function, cisplatin combined with gemcitabine is the standard.
But what if they don't?
For patients with borderline renal function or maybe neuropathy issues, the guideline shifts to carboplatin.
Carboplatin, okay.
Yeah. Carboplatin shares a similar DNA cross-linking mechanism to cisplatin, but it has a different biochemical structure that alters its excretion profile.
Making it easier on the kidneys.
Exactly.
Yeah.
It makes it significantly less toxic to the kidneys, though it is slightly less aggressive against the tumor itself.
Got it. Now, the true paradigm shift in the guideline happens in the period immediately following that first line of chemotherapy.
Hmm.
Historically, if the chemo successfully shrank the tumors, the protocol was just watchful waiting, right? You simply monitored the patient until the cancer inevitably began to grow again.
That used to be the standard, yeah.
But now, the guideline mandates a maintenance strategy. If the disease does not progress on initial chemotherapy, the patient is immediately transitioned to an immunotherapy drug called avolumab.
Right. And the clinical trial data for evolumab maintenance completely rewrote the standard of care.
Oh, really?
Yeah. Transitioning patients to this immune checkpoint inhibitor immediately after chemotherapy extended the median overall survival from roughly 14 months to over 21 months.
Wow, 7 extra months. I really want to look closely at how a checkpoint inhibitor actually functions because it's fundamentally different from traditional cytotoxic chemo. Like, it doesn't poison the cell directly.
Right. No, it doesn't poison anything. It acts on the immune system's braking mechanism.
Okay.
So T cells have receptors like PD-1 that act as an off switch.
Right.
This prevents them from attacking normal, healthy tissue.
That's a good thing to have.
It is. But urothelial cancer cells frequently exploit this by expressing a protein called PD-L1 on their surface.
Ah.
So when the T cell approaches the tumor's PD-L1 binds to the T cell's PD-1 receptor, and it essentially flips the off switch.
So the immune system just ignores it.
Exactly. The tumor basically creates an invisibility cloak.
Okay, so where does avolumab come in?
Avolumab binds to PD-L1, physically blocking that interaction. It strips away the invisibility cloak, which allows the T cells to actually recognize the tumor as hostile and destroy it.
So by deploying avolumab right when the tumor is weakened from the chemotherapy, the immune system is able to maintain the pressure and delay the relapse. But if the disease eventually does progress, the guideline outlines a transition from broad systemic therapies to highly individualized genomic targeting. And this is where I wonder, how do doctors possibly choose between this massive alphabet soup of new drugs? Is it just trial and error, hoping one works?
Not at all. What's fascinating here is the complete departure from treating urothelial carcinoma as a single monolithic disease.
Okay.
In the second and third line settings, the treatment is entirely dependent on the specific molecular fingerprint of the patient's individual tumor.
How do they find that out?
The oncologist will order next-generation DNA sequencing on the biopsy tissue to identify specific actionable mutations.
A prime example of this in the guideline is a drug called erdafitinib.
Yes.
It's specifically indicated only for patients whose tumors possess a genetic alteration in the FGFR gene.
Right. FGFR stands for fibroblast growth factor receptor. These are basically tyrosine kinase receptors that sit on the surface of cells, and they regulate cell division and growth.
Okay.
In a subset of bladder cancers, the DNA coding for these receptors is mutated, causing the receptors to become permanently stuck in the on position.
Oh, that sounds bad.
It is. They constantly flood the cell with signals to proliferate, which drives rapid tumor growth. Erdafitinib is a targeted kinase inhibitor. It's physically designed to bind to these malfunctioning FGFR receptors and block the cascade, cutting off the growth signal at the source.
Wow.
But if a patient does not have the FGFR mutation, erdafitinib will do absolutely nothing. The drug is entirely dependent on the presence of that biomarker.
Okay, so if the tumor lacks that mutation, the guideline introduces one of the most mechanically sophisticated drugs in modern oncology, which is enfortumab vedotin, or EV.
EV is incredible, yeah.
I was looking at the structural makeup of EV, and the mechanism here operates exactly like a biological Trojan horse.
It really does.
It belongs to a class of drugs called antibody-drug conjugates. If I'm tracking the biology correctly here, the outer shell is a monoclonal antibody specifically engineered to hunt down a protein called Nectin-4. And Nectin-4 is heavily overexpressed on the surface of bladder cancer cells, but rarely found on healthy tissue. So the antibody locks onto the Nectin-4 receptor, and then the cancer cell just absorbs the entire structure.
Yes, and that absorption process is the key to the whole thing.
Right.
The antibody is chemically tethered via a proprietary linker to a highly toxic payload. Now, while the drug is circulating in the bloodstream, that linker remains totally stable. It protects the patient's healthy tissue from the toxin.
Okay.
But once the complex is swallowed by the cancer cell, it gets enveloped in a cellular compartment called the lysosome.
And the lysosome is highly acidic.
Precisely. The acidic environment of the lysosome cleaves that chemical linker, releasing the payload directly into the cytosol of the cancer cell.
Boom.
Boom, exactly. The payload in enfortumab vedotin is a microtubule disrupting agent. Microtubules form the structural scaffolding of the cell, right? They are absolutely essential for cellular division. So by releasing the toxin intracellularly, EV shatters the cancer cell's structural integrity and its ability to replicate. It maximizes the lethal impact on the tumor while significantly mitigating systemic toxicity.
It's just a phenomenally smart drug. You know, when we pull back and look at the trajectory of this entire ESMO guideline, the narrative of modern oncology becomes incredibly clear.
It really paints a picture.
It does. We started with the vital importance of recognizing a silent, painless symptom. We saw how a 100-year-old tuberculosis vaccine is still utilized to trigger a localized immune swarm against superficial disease. We explored the strategic fumigation of neoadjuvant chemotherapy to hunt down micrometastases before a life-altering surgery. And finally, we tracked the disease into the genomic era, where therapy relies on unmasking cancer cells with checkpoint inhibitors and delivering intracellular payloads via antibody-drug conjugates.
If we connect this to the bigger picture, the sheer density of this guideline illustrates that medical science is engaged in a continuous iterative feedback loop.
Yeah.
Every overall survival curve, every nuanced dosage adjustment for renal impairment, and every newly identified biomarker is built on the clinical data of thousands of patients. The standard of care is not static. It's constantly evolving to outmaneuver the adaptive biology of the tumor.
Absolutely. And the immediate takeaway for anyone listening is a powerful reminder about bodily awareness. You know, a symptom doesn't need to be agonizing to be critical.
No, it hasn't.
Ignoring a painless physiological change just gives an aggressive biology a head start. But simultaneously, understanding the depth of this document is profoundly reassuring.
Oh, I agree.
The medical community approaches this disease with an incredibly sophisticated, multifaceted strategy that is increasingly tailored to the exact genetic makeup of the individual.
It's hope. Real data-driven hope.
It is. As we close out this deep dive, consider the trajectory of these treatments for yourself. We've moved from physical resection to total organ removal to systemic cellular poisons, and now to microscopic, receptor-specific Trojan horses like enfortumab vedotin. As these antibody-drug conjugates and targeted genetic therapies continue to achieve higher complete response rates and longer durable remissions, we have to ask where the curve is heading.
Right.
How long will it be before these intracellular targeted strikes become so overwhelmingly effective that they render radical cystectomies obsolete? Are we approaching a horizon where we can entirely eradicate muscle-invasive disease without ever needing to make a surgical incision?
It's a fascinating thought.
Something to think about. Until next time, stay curious and listen to your body.